Hey everyone, in this session, we're going to go through pleural effusion using a simple clinical blueprint approach. We'll focus on the diagnostic algorithm, the underlying pathophysiology, and the high-yield concepts that commonly appear in exams and clinical practice. The goal is to understand not just what pleural effusion is, but also how to approach it step by step at the bedside. Let's start by defining pleural effusion. A pleural effusion is an abnormal accumulation of fluid in the pleural space. On the diagram, you can see fluid collecting around the lung. The major causes highlighted here are congestive heart failure, pneumonia, and cancer. These represent some of the most common etiologies encountered in clinical medicine. So whenever you see pleural fluid, think broadly in terms of cardiac causes, infectious causes, and malignant causes. Now let's understand the pathophysiology. Pleural effusions are broadly divided into transudative and exudative types. A transudative effusion happens because of an imbalance between hydrostatic and oncotic pressures. In other words, fluid is pushed out or not adequately pulled back into the circulation. An exudative effusion, on the other hand, develops because of increased capillary permeability or impaired lymphatic drainage. This usually occurs in inflammatory, infectious, or malignant conditions. This distinction is extremely important because it guides the diagnostic workup. Clinically, patients with pleural effusion commonly present with dyspnea. On physical examination, you may find dullness to percussion, decreased or absent tactile fremitus, and reduced breath sounds over the affected side. The imaging examples here demonstrate two classic findings. In the upright chest X-ray, notice the blunting of the costophrenic angle. On the lateral decubitus view, free-flowing fluid layers dependently. A very high-yield board concept is the 1 centimeter rule. If there is more than 1 centimeter of fluid on the decubitus film, that usually indicates a clinically significant amount of pleural fluid. Once a clinically significant effusion is identified and the diagnosis remains uncertain, the next step is diagnostic thoracentesis. Pleural fluid should be analyzed for protein and LDH, which are required for Light's criteria. Additional routine studies include glucose, cell count, gram stain and culture, and cytology. Depending on the clinical suspicion, targeted tests may also be added, for example, amylase, triglycerides, cholesterol, hematocrit, or flow cytometry, if lymphoma is suspected. The key idea is that thoracentesis transforms pleural fluid into diagnostic information. Now we come to one of the most important exam topics, Light's criteria. A pleural effusion is classified as exudative if any one of these criteria is met. First, the pleural fluid to serum protein ratio is greater than 0.5. Second, the pleural fluid to serum LDH ratio is greater than 0.6. Or third, the pleural fluid LDH is greater than 2/3 the upper limit of normal for serum LDH. Remember that only one criterion needs to be positive for the effusion to be labeled exudative. Sometimes the cause of the effusion remains unclear, even after the initial evaluation. In such situations, there are three important next steps to consider. First, repeat thoracentesis. Second, evaluate for pulmonary embolism. And third, consider a pleural biopsy, especially when malignancy or tuberculosis is suspected. The high-yield caveats on the right are also important. Congestive heart failure can occasionally satisfy the criteria for an exudative effusion, especially after diuretic therapy. Pulmonary embolism can produce pleural effusions that are either exudative or transudative. Management depends on the underlying etiology. For transudative effusions, treatment targets the underlying cause, while therapeutic thoracentesis is primarily used when the patient is symptomatic. For malignant effusions, management may involve indwelling pleural catheters or pleurodesis, especially in recurrent or symptomatic cases. Parapneumonic effusions are treated by managing the pneumonia itself, and chest tube drainage is usually not required unless complications develop. In hemothorax, prompt treatment is critical because retained blood in the pleural space can organize and progress to fibrothorax. Here we focus on empyema, an infected pleural collection. Chest tube insertion is strongly indicated when there is evidence of empyema. Key indicators include a pleural fluid pH below 7.2, the presence of pus, glucose less than 40 milligrams per deciliter, or a positive gram stain. If any of these features are present, prompt chest tube drainage should be performed. This final algorithm ties the entire approach together. We begin with suspicion of pleural effusion based on symptoms, physical findings, or imaging. A chest X-ray with lateral decubitus imaging helps determine whether the fluid is clinically significant. If indicated, diagnostic thoracentesis is performed. The fluid is then classified using Light's criteria into either transudative or exudative. Transudative effusions are managed by treating the underlying systemic condition, such as heart failure or cirrhosis. Exudative effusions require a more targeted investigation for causes such as malignancy, infection, pulmonary embolism, or inflammatory disease. This structured approach is what makes pleural effusion evaluation both systematic and clinically efficient. That concludes this clinical blueprint on pleural effusion. The key takeaways are to distinguish transudative from exudative effusions, use Light's criteria appropriately, and always connect management to the underlying etiology. If you found this useful, make sure to review the flowchart again because that framework is extremely valuable for exams, ward rounds, and clinical reasoning.
This content is not intended for clinical guidance, use in medical clinics, or patient management. It serves as supplementary information for medical students preparing for examinations and should be used in conjunction with their official course materials. In the event of any discrepancies between this content and the prescribed curriculum, the curriculum shall take precedence until further review and clarification are made by the concerned students. The contributors to this video have exercised due diligence, but the content may become outdated quickly.